thank the organizing team, Dr. Kamal sir, the entire team from Mohawk Hospital and the AMA for this fine invitation. And I take this opportunity to talk about the approach to malignant breast lump. Just a small correction to the introduction. So, very recently, I have now shifted to the private sector, and I am now working at my own center, which is Upkar Cancer Institute and Upkar Hospital in Varanasi. So, with this, I would continue with my presentation. So, why are we talking about breast cancer today? We are talking about breast cancer today because as we talk, every 4 minutes, some Indian woman is being diagnosed with breast cancer, and every 13 minutes, a lady is dying of breast cancer in India. So, that is why it is important. 1 in 8 women sitting in this hall would be probably diagnosed with breast cancer in their entire lifetime. So, such is the high risk. So, this is why it is important for us to be all aware of breast cancer. And it is, all I can say is it is a common and a dangerous cancer. So, I like to focus about some points. There are, as we talk about the management strategies, so many people here sitting are have done their education from esteemed institutes, have been exposed to best and best of facilities. But when we practice surgical oncology or cancer surgery in a tier three or a tier two city, we don't have access to all those facilities, and that is what complicates the management of these cancers, specifically cancers I will talk about, because it involves a lot of technology as well. And probably living in in Allahabad or Varanasi or probably other regions of Purvanchal, we would not have access to all these care which will ideally be available in tier one city. Most of the evidence which is available to us is from the Western world, from US, UK, Australia, where the patients who are being treated with the best and best of facilities. The patients are very educated. So while we talk about evidence, I think it is very important for us to acknowledge that the patient population which we are treating is not very literate, is not very compliant, and there are several problems with the lack of technology which we face as a surgeon when we are sitting in our OPD and operating in our operation theater. So we have to shift from an ideal management to what is an acceptable management. Poor finances of the patient, long distance for patients who are traveling from villages for their treatment, the travel time, poor compliance, and the lack of availability of these best resources complicate our decision making. So we have to know when we should be treating these patients and when we should be referring these patients for the most superior technology or treatment available. So today I'll be talking about breast cancer in terms of early breast cancer, locally advanced, and metastatic breast cancer. The stage has already been set by ma'am presentation earlier this evening, where she has spoken about the grades of tumor and the stages of tumor. Just a very basic thing. Whenever we talk about a lady presenting with breast lump, dictum is triple assessment of the breast lump of the lady. And this triple assessment has three things: examination by a clinician or who is doing a clinical breast examination. Second is a radiological assessment by a radiologist in the form of a ultrasound or a mammography. And third thing is a biopsy. In today's date and age, it is safe to say that a true cut core needle biopsy is the standard of care when trying to diagnose breast cancer. So with this, I'll move forward, and I have developed a case-based approach for today's presentation. So case one deals with management of a lady who was presented to us with a very small tumor. 45 years lady who was presented to us with a small lump in the right breast, no palpable axillary lymph nodes, and opposite breast and axilla is normal. And this is the mammogram, and we have been able, there's a single lump, there are no lymph nodes, opposite breast is normal. Biopsy has shown a infiltrating ductal carcinoma. I will not go into the pathological details, but hormonal receptor profile showed ERPR negative and HER2 2 plus. First, very basic question. It's a very small tumor in the breast. It's a breast cancer. Had I not done the core biopsy, could I have gone ahead and done a excision biopsy and removed the lump? She's a 45 years lady. It could be a fibroadenoma or it could be anything. Am I right? This question should be the first thing which should come to my mind when I am seeing her in my OPD. So no, in if the lump is suspicious clinically, excision biopsy is absolutely wrong, and we should not be going ahead with it. That is why true cut biopsy is the standard of care in today's date and age. Now, second question which we come to, what further investigations do we advise to this lady who's presenting with a small breast lump? Do we need any investigations? Do we need any ultrasound? Do we need any chest X-ray? Second option, should we go ahead and advise a CT scan? Should we go ahead and advise a PET scan? PET scan today is very fashionable. Any patient who gets uh, diagnosed with cancer, the first thing, if finances are not a limitation, they will say, "Sir, मैं एक PET scan करा लेता हूँ." So, if we talk about guidelines for a early breast cancer, for small tumors, and the patient is asymptomatic, ideally no metastatic workup is indicated. At the most, uh, we can try and get an ultrasound of the abdomen and pelvis and a chest X-ray, and that would be sufficient. PET scan, absolutely not for early breast cancer. It's not at all recommended. It's only recommended for locally advanced tumors, because the risk of distant metastasis, which we are trying to pick up with these investigations, is very less, which is less than 1%. Should we get any other investigation for locating or localizing the primary tumor in the breast, specifically MRI breast, which is not widely available in tier 2 and 3 cities, but still. So there are very specific indications of when to advise a patient for a MRI breast, and if and whenever we are advising this, we should be sure to refer this patient to a center who has a MRI machine with a dedicated breast coil. Only then it will have any bearing and a meaning. So there are several indications. I will not go through in detail, but familial breast cancers, particular histological variants like lobular cancers, dense breasts which are not easily which cannot be easily examined on mammography, young patients when there is suspicion of multicentric tumors are probably some of the common indications for getting an MRI done for these breast cancer patients in the preoperative period. Next, coming to the second point, treatment options. Surgery or chemotherapy. These are the two options which come to my mind first. If I decide for surgery, what should I be offering to this lady? Should I be offering a breast conservation surgery, or should I be going ahead with mastectomy? Is one. Second, should I address the axilla, as in should I do a axillary dissection? If yes, should I be doing a complete axillary lymph node dissection, or should I be doing something smaller than that, which can be something like a axillary sampling or a sentinel lymph node biopsy? So these are the published guidelines for management of early breast cancers. And in general, I can say that there are particular molecular phenotypes which need more chemotherapy earlier on as compared to the other tumors. And specifically, if I talk about, as ma'am has already told, certain tumors like HER2 positive tumors and triple negative breast tumors will benefit more by chemotherapy in the upfront setting prior to surgery, which is in the neoadjuvant chemotherapy setting, and then surgery later. And otherwise, hormone receptor positive patients, ER positive, PR positive patients with small tumors can go for upfront surgery. The decision whether to do upfront surgery also depends whether the lady wants a breast conservation surgery or she wants a mastectomy. If the lady says, no, I want my breast to be saved, I don't want it to be gone, then we have to decide, if we are trying to save the breast, are we going to give her a good cosmesis while saving her breast? Because is the tumor that small, or is we have to see how big is her breast and how big is her tumor? We have to see the breast tumor ratio. And if the breast tumor ratio at that point of time is not very favorable for saving her breast, then we can probably offer her chemotherapy and then operate her after chemotherapy. And there are several studies and several indications for giving neoadjuvant chemotherapy, but this is the overall gist of when to offer neoadjuvant chemotherapy for high risk patients, for triple negative patients, for HER2 positive tumors, big tumors, and when even in favorable patient, if the breast tumor is larger in compared to her breast size, and she will not get a good cosmesis with a breast conservation surgery then. And a very common question which patients ask, अगर मैंने ब्रेस्ट बचाया तो क्या मेरे कैंसर मैस्टेक्टमी के कंपैरिजन में कैंसर वापस आने का चांस ज्यादा रहेगा? तो नो, देयर आर ample amount of studies, literature is full with these studies, and which have shown over time that breast conservation is as safe at least as mastectomy. The newer advances, something which we know is sentinel lymph node biopsy. Why should we talk about sentinel lymph node biopsy and what is it? So over the years, over past 20-25 years, if I can say that there has been a trend, while there has been a trend to be doing aggressive surgery, there is also now a realization that the outcomes are improving. And as the outcomes are improving, the next thing is you would want to reduce the side effects of those treatments which you are giving. As a surgeon, if I am doing a mastectomy, then the next question which the demand comes from the patient says is, can my breast be saved safely? And second thing is, while I am doing breast conservation or doing mastectomy, when I'm doing axillary dissection, there was a time when people started doing complete axillary dissection. There was focus in doing more and more axillary dissection from level 1 and 2 to level 3 axillary dissection. But now there is a downward trend. We have started identifying those patients which will benefit from lesser amount of surgery. And this lesser amount of surgery, there are 2-3 patterns of doing it. One of them is called axillary sampling, and the other, which is a relatively newer technology, or a procedure called a sentinel lymph node biopsy, which is done in several cancers, breast cancer being one of them. Here, particular or the first draining lymph nodes in the axilla are identified using particular dyes which are injected around the primary tumor. And there are several dyes, there are several methods. Most common is methylene blue, which is very easily available and accessible to most of us who are there. Some dyes like indocyanine green are less easily available in tier 2 and tier 3 cities. And then there are more advanced technologies like radionuclide dyes, which are radioactive and need specific equipment like gamma camera, technetium sulfur colloid dyes, which can help do these procedures. One or more of these dyes, when used, help us do the sentinel lymph node biopsy. Several trials have been done, and over the time, it has shown that sentinel lymph node biopsy, when done in appropriately selected good patients, provides very good result without compromising any cancer control. And so this is a patient which I operated recently, and for this meeting I chose to draw a diagram just to give a gist of what is meant by sentinel lymph node biopsy and by low axillary sampling. So here is the real-time picture of the patient, and here are the two diagrams which I drew on the sheet after the specimen. So this is the area of axilla after the dissection. So initially, I had just used methylene blue dye to find out the draining lymph nodes, or the most representative, those nodes which were most likely to get affected first, get affected by the cancer. And these were the sentinel lymph nodes. You can see the blue staining over here, and the landmarks of the axillary dissection during this course. That is the axillary vein, the intercostobrachial nerves, the latissimus dorsi pedicle, and the latissimus dorsi muscle here, and the chest wall over here. So we can see that we have tried to save. This patient did not have any palpable nodes. She was a very good patient. I wanted to offer her all the advantage of her smaller tumor. So I preferred to do a sentinel lymph node biopsy for her. And then here we can see the axillary sampling, which is, these are the boundaries of doing axillary sampling. Meaning to say, these procedures are done so as to reduce the morbidity of the surgery. The morbidity which I am going to offer to the patient after the surgery is lymphedema. The chance that her limbs will get swollen over the next 5, 10, 15 years. So I'm trying to reduce that, because she has come to me with a very early tumor. I'm trying to give her the advantage of that. So this lady eventually underwent that, and she had eventually had a T2 tumor, node negative. This was how the primary tumor looked after excision. This was a size. And luckily, her breast tumor volume was feasible. She was very insistent on getting a breast conservation done, and this is we had to do a type 1 oncoplasty for this. Sir, I think later is going to talk about more about oncoplasty, so I'll not go in this detail. Later on, we went and completed her further treatment in the form of fish testing for her to new, and then further chemotherapy and radiotherapy. Can chemotherapy be avoided in certain situations? Yes, for there are several tests available, which ma'am was already trying to tell in the later part of her presentation. There are several molecular tests, oncotype DX, mamma print, but I can say that probably in our population, these tests are applicable to very few patients. At least what I have been seeing in my practice over the last 5 years, very few patients present to us with so early tumors. These tumors have to be really T1 or T2 size and node negative tumors. The hormonal receptor profile has to be very favorable. But yes, we should be aware of it. As and when we come across such patients, it's our duty to at least offer them that. These tests are costly. They cost around somewhere around 40,000 rupees to 60,000 rupees. So when we talk about advising these tests, we have to bear the cost also in our mind. Coming to the second case is a little more advanced tumor, which I'll call as a locally advanced breast cancer. And here the lady has presented to us with a bigger lump and with a lymph nodes in her axilla, which are palpable, which I can obviously palpate. But there was no other signs and symptoms to suggest that there is a disease anywhere else. So, as per the guidelines, I chose to get a PET scan done for her. And in the PET scan, I can see that there is a tumor which is there in the breast and there is a tumor in the axilla, as seen here. As per the protocol, I went ahead and did a core biopsy again for her. And here the hormonal profile was different. It was a ER positive, PR positive, and a HER2 positive tumor. So patient again in this, as per the guidelines, it was a biggish tumor. It was a high risk tumor. I gave her neoadjuvant chemotherapy. And then we did a mastectomy with axillary dissection for the patient. And on the final result, we found that there was a residual tumor. The surgery was adequate, and then we chose to give her further chemotherapy. The question I like to highlight is breast conservation possible in such locally advanced cases? Can we offer breast conserving surgery to these patients who present to us with not so early tumors but little advanced tumors? Yes, it is possible now. We have enough amount of literature, enough amount of data. If we have good plastic surgery backup with good techniques, this is a case which is done, which I did with the help of my plastic surgery friend, who actually ultimately ended up giving a very good prognosis to this lady. And in the sitting position, one cannot make out whether she has ever undergone any breast surgery. So the debate between breast conservation and mastectomy will continue. The single and the first most important thing which I feel we should all acknowledge is that the patient should be knowing what she is undergoing. If we are going to offer breast conservation, the lady should be ready to take further radiation therapy. That is number one. For taking radiation therapy, there should be a radiation therapy machine available in that city or in that region. Patient should be in a comfortable traveling distance and a travel time to receive that radiation therapy. If we are doing breast conservation surgery and then not offering her radiation therapy, it is much better than to do a mastectomy to that patient. So these are some examples of the procedures which we have been doing over time of breast conservation, and we can see uh, tumors in different locations demand different kind of reconstruction, but eventually have good processes which can be given. Can our radiologist colleagues help increase our accuracy and quality of surgery? Yes, there are several procedures like um, the breast clipping wire localization, which through which we can identify these tumors specifically if we have earlier giving these patients chemotherapy and then we choose to operate later on. So the USG guided intervention can help increase the accuracy of our surgery. So in this particular case, she was a very young lady, very desirous of breast conservation, but she had an advanced tumor. We gave her chemotherapy, it completely vanished. So now we had another problem. We did not know now where to excise, where not to excise, and so we did took the help of our radiologist, chose to localize that tumor with the help of wire insertion, and did a wider excision. And then with the help of our plastic surgeons, we chose to do a good reconstruction for the lady. So going on to the further treatment, which is called the adjuvant treatment after the surgery, there are several things which we have to think about. What hormonal treatment to give? Is there any other immunotherapy or anti-HER2 treatment which we can give against the HER2 receptor positive? Should we give any radiation therapy to the patient or should we not give any radiation therapy? And when we are giving hormonal therapy, there are several things which we have to decide. Which agents do we give? Do we give tamoxifen? Do we give AIs, aromatase inhibitors? How long do we give these treatments? Do we need to change the medications over the course of years? So, lot of debate, lot of data is there. For hormone receptor, I'm going to keep it simple. For hormone receptor positive patients, it is recommended to give hormonal treatment for at least 7 to 10 years. Trials have shown it very clearly that there is a good survival benefit and there is a reduction in mortality if we give this adequate hormonal treatment. And tamoxifen or aromatase inhibitors like letrozole can be given based on several risk profile of the patient, her risk factors like her osteoporosis, her bone density, whether she is premenopausal, postmenopausal, and which can help us to decide which treatment to give. Usually, endocrine therapy or any adjuvant treatment is given after completing chemotherapy and after completing a radiation therapy. Then the patient is put on a long time of endocrine treatment. And I'll not bore with the guidelines which is available. There are several guidelines which are available in detail when and when not to offer and drugs and which drugs to offer. A very common question which ladies often ask, specifically when premenopausal, क्या chemotherapy के बाद मेरे periods वापस आएंगे? So for this, there are enough number of literature which is available for doing ovarian suppression. That is, you have to preserve the ovaries. When the ovaries will be preserved and not killed by the chemotherapy, they will still function once the chemotherapy or the treatment has gone. So this ovarian suppression, when we give chemotherapy to the patient with the help of certain drugs, we will suppress her ovarian function. When the ovaries will function less during the course of chemotherapy, they are less likely to get damaged by the chemotherapy. And once we have finished our chemotherapy, we can remove that, and the ovaries will start functioning again. And which good functioning ovaries will give a lot of benefits to the lady later on. Several trials. These are the most common, most famous trials for this: text trial and soft trial. And so, and then I'll come to be talking about radiation therapy. And there are several advances in radiation therapy. Nowadays, good machines, good techniques, which have reduced the toxicity of radiation therapy. A particularly new technique, which is now called APBI, accelerated partial breast irradiation, which has actually reduced the number of radiation cycles and the timing and the duration which is needed for radiotherapy. When the timing is reduced, the cost is reduced, and the compliance of the patient increases. जब patient को 15 दिन नहीं आना पड़ेगा radiation therapy के लिए, and the same thing gets done in 5 days, it is more logical that the patient is going to complete her treatment more. So this is how APBI looks like. During the course of surgery, we insert radiation therapy wires and then later give radiation therapy through those wires. What is the role of plastic surgeons? Plastic surgeons, we have, as cancer surgeons, we have to make them our best friends, because we are just going to remove the tumors. Ultimately, the ultimate satisfaction the patient gets is मेरे टाके कितने लगे हैं, मेरा ब्रेस्ट अच्छा दिख रहा है या नहीं दिख रहा. They are not going to be bothered at that point of time कि मैंने कितने lymph nodes निकाले हैं या कितने accuracy से सर्जरी की है. So plastic surgeons have to be our best friends, and a good plastic surgeon, with the help of the free flaps, with various local flaps, can make your life so easy and make the patient so much comfortable. So I am very fortunate to have a very good friend of mine, Dr. Prince, who has been my junior from AIMS, and then we did our MCH together from Tata, and he's now associated with me at my new center as well. And we try and offer free flaps at good cost to the patients, so that they benefit more. This is one such case where a DIP flap was offered, giving a good breast reconstruction. Here for bilateral, this was a BRCA, I'm sorry for the spelling mistake, for a BRCA positive patient where bilateral mastectomy was done, and with the help of a good abdominal flap, the DIP flap, deep inferior epigastric perforator flaps, both the breasts were reconstructed for the lady. So after Angelina Jolie, we are now all talking about BRCA positive tumors, BRCA1, BRCA2 genes. The people, educated people, are coming and talking about the risks of developing breast cancer in the other breast or familial breast cancer. And when we talk about something like a prophylactic surgery, when there is no cancer but we still want to get a surgery, we have to be sure that along with the surgery, we also offer something more to the patient, which is a very good cost method because the patient can have a good social life as well. And this is one more technique which my plastic surgeon is now doing. This is a very new procedure, a very few centers are doing, which is called as lymphatic microsurgical prevention healing approach. Here, I'll just take a couple of more minutes. And here, the plastic surgeon, using their micro instruments and loops, they anastomose the lymphatics to the veins after the end of axillary dissection. After I have completed my job, he will come and do the anastomosis, and thus the risk of lymphedema to these patients later on is going to be very less. So these are very new things, and this has been started in US, and now surgeons are going there and getting trained and bringing the same concept back to our country. I'll skip this. This was about a case about metastatic breast cancer, and all I can say is for metastatic breast cancer, we have a lot of new agents for treatment. Anti-HER2 drugs. There are so good drugs which are available. Trastuzumab. There is a very recently imported drug in the country, trastuzumab deruxtecan, which is very costly, which is 60,000 rupees per dose. As in 1 month, a dose is going to cost 60,000 rupees, but it's very effective. And with the help of these drugs, even stage 4 tumors, patients can live for 5-6 years easily if an appropriate treatment has been given. Other thing is, this is a very common scenario which we see when practicing as surgeons in tier 2 and 3 cities, these big dirty tumors. Uh, Sometimes they need surgery even when they are stage 4, and sometimes not. The surgery is not going to benefit, but probably can provide a better quality of life for some time till the lady is alive. All stage 4 are all stage 4 tumors incurable? No. There is a term which is called as oligometastatic, where we characterize the burden of the tumor and then we give the treatment accordingly. And with this is one case which I thought I had
यार
where
हम कल देख लेंगे उसको सब सामान
tumor and metastasis to bones. But given the appropriate sequence of treatment, patient still continues to live a good life at around, I think, 3.5 or 4 years now. So we have come a long way from doing radical mastectomy to breast conservation, from oncoplasties, whole breast reconstructions, from only palliative treatment to these stage 4 patients to now trying to treat them with a curative intent. We are now trying to cure even these advanced patients with such treatment that they are going to get at least 4-5
चुके सब इंतजाम कर दिए
from techniques of radiation therapy which were very
अरे तो
morbid.
सात
Now,
बार मिल के तो आए
very
हैं
advanced techniques of radiation therapy.
हमने कहा कल निकाल
There
देना
has to
हम
be a
आएंगे
very
सुबह
fine balance which we have to make between oncological
काट दो
safety, a
काट
good
दो
cancer
बस
control,
काटो
but also
अब भारी आवाज हुआ
to give good cosmetics to the patient, a good functional life, social life to the patient, and a good quality of life to the patient. And this is possible only with a good team approach. You have to make radiologists your friend, medical oncologists your friend, plastic surgeons as your friend, and radiation oncologists as your friend, and obviously surgeons have to be friends. So this is all I can say. That this is the slide with which I began with. We practicing in tier 2 and 3 cities, having all the knowledge in mind, still we have to make a compromise between ideal management and what is a bare minimum acceptable management. Uh, when I can treat, when do I need to refer? As a surgeon, I need digital mammograms, I need intraop mammograms, I need breast interventional radiologists, I need PET scans, I need gamma cameras, I need a good frozen section facility, I need facility for free flap surgery, I need newer techniques for radiation therapy. Which of these is available in my city and in my gamut
यार
of treatment options? I have to decide my eventual treatment. I just don't have to follow the guidelines blindly, which is provided by the Western world, but I have to cater to my patient. And as ma'am had said in a presentation, today is the era of personalized medicine. We have to
उस दिन
offer
हमको
treatment
चलवा के लेके
what
आइए
is best suited to this patient, and all very good options are now available to us. with this, I would like to say thank you for very patient hearing today. Thank you.
Very